The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/GKC860. Downloadable slides and practice aids are also available.
Hi, everyone. It's great to be here for our presentation at ACEP 2020, Solving Oncologic Emergency Quandaries During the Immuno-Oncology Era and the COVID-19 Pandemic. Thank you for joining us. We're disappointed we can't be with you in person, but it's 2020 and we've all learned to make do. And I'm glad that we have this opportunity to give this presentation to you virtually, because I think it's really important and I think it's going to change your practice as it's changed mine. I'm Andrew Stolbach. I'm an emergency physician and a medical toxicologist at Johns Hopkins University. And I'm joined by Jarishka Naidu, who is a recent colleague of mine at Johns Hopkins University as well, who's coming to speak to us from Dublin. So our goals for today, so what we want you to walk out of here with is to become familiar with these cancer immunotherapies and the adverse events associated with these therapies. So I said this, and I'm going to say it maybe again. I'll probably say it a few more times. The paradigm's changed. So you're going to be seeing a different class of cancer therapy. And when you see this class of drugs, you're going to treat the adverse events differently, and they're going to present differently. So we just need to be able to recognize these. So when we take a history, the first thing, right, we're not gonna know to recognize these events if we don't even know the patient's taking these drugs. So we're gonna ask about cancer diagnosis and treatment history. Now, what may be a change from all of our practices, maybe a change for your practices, we're used to asking, what drugs are you taking now? We're used to asking, what drugs are you getting now for your cancer? What drugs did you get in the last couple of weeks for your cancer? The change in our practice is going to be when we take their history, we want to know, what drugs have you gotten in the course of your treatment, right? What have you gotten in the last year or two for your cancer? Which leads us to number two, talk to the oncologist. We really want you to be able to reach out to the oncologist and find out about the patient's treatment, find out what drugs they're taking, because right, the patient's got a lot going on. They might not know what ipilimumab is, nivolumab is. They might not know that their medications, what their medications are called, or that they're a checkpoint inhibitor. You reach out to the oncologist and they're going to help steer us towards recognizing what medications patients are on. So once we've taken this history and we've reached out to the oncologist and we know they're on a checkpoint inhibitor, we're going to have a broad differential diagnosis. So as we're going to see later, you see that patient with a cough. And in addition to worrying about bronchitis and pneumonia, now we know they're on a checkpoint inhibitor, and we've added to our differential diagnosis, and we're going to add immune-related adverse events. So again, we're going to get really in depth into this later, but just setting the table for you. And finally, so we've taken the history. We figured out that they're on a checkpoint inhibitor from taking the history and talking to the oncologist. We've added checkpoint inhibitor related immune-mediated toxicity to our differential. Now we can get to treatment. And the best part of this presentation is we are not here today to tell you to use some medications that you're unfamiliar with. We're not here today to tell you to use some exotic treatment. Dr. Naidu and I are going to explain to you that for the vast majority of these cases in the emergency department, when we suspect this, when we identify these immune-related adverse events, you're going to be using steroids. Right? You're going to be using corticosteroids, which are medications which, as emergency physicians, we're already using every day. So we're not going to be asking you to use some fancy, new, expensive drug that you're unfamiliar with. We're actually just asking you to use medications that you're really comfortable with and really used to using. So I think it's really like a message of hope, and it's a message of empowerment that we're going to be able to identify this and we're going to be able to treat this in the emergency department. So I'm going to hand it off to Dr. Naidu to talk about the nuts and bolts of the basic science behind these cancer immunotherapies.
Well, thank you, Andrew, for that kind introduction. So today we'll be talking about what emergency medicine professionals need to know about cancer immunotherapies and the toxicities they cause, which are called immune-related adverse events. So checkpoint inhibitors are the type of immunotherapy we're going to talk a little bit about today and to explain how they work. So immune checkpoint inhibitors are one class of immunotherapy, where immunotherapy refers to a cancer treatment that tries to harness the body's immune system to fight cancer. Immune checkpoint inhibitors are one particular type of immunotherapy, and what they do is they block the interaction between our T cells and the tumor cells. So at present, there are molecules expressed on the surface of both T cells and tumor cells that inhibit the interaction between these two cell types, or in fact, inhibit the T cell's ability to eradicate the tumor cells. And these molecules are called checkpoint molecules. And they are therefore negative regulators. They regulate this negative interaction between the two cell types. And what immune checkpoint inhibitors do is they inhibit this negative signal, and therefore they release the anti-tumor activity of the T cell and allow the T cell to in fact kill the tumor cell. And we know that there are a number of immune checkpoint molecules that may be expressed on the surface of T cells, such as PD-1 and CTLA-4. CTLA-4 was first identified in the early 2000s and PD-1 later on. PD-1 then attaches to its ligand molecule on the surface of tumor cells, and that ligand molecule is called PD-L1. So the way the T cell's PD-1 interacts with the tumor cell's PD-L1 is what we call the immunologic handshake. And this allows the T cell to in fact kill the tumor cell and underscores the activity of immune checkpoint inhibitors in cancer. So what we have seen in the last number of years is that there are a number of checkpoint inhibitors that either block PD-1, block PD-L1, the ligand, or block CTLA-4. And there have been a number of FDA approvals for drugs that block each one of these molecules either as monotherapy or approvals where these agents have been combined with traditional cancer therapies such as chemotherapy, targeted therapies such as axitinib, or anti-angiogenic therapies such as bevacizumab. So therefore, immunotherapy, as Andrew mentioned, has really changed the face of treatment for cancer, either when given as a monotherapy or in combination with various standard treatments that we have used routinely for cancer. What's also been impressive is that immune checkpoint inhibitors have now been licensed in over 15 different cancer indications. And these range from tumor types that we have been accustomed to using immunotherapy for, such as melanoma or renal cell carcinoma, even to cancers that we didn't expect to be particularly sensitive to immunotherapy, such as lung cancer, which is an area that I specialize in. So really, immunotherapy has changed the face of cancer treatment in general, and not just for certain tumor types, really for many tumor types. So we have also seen an evolution of the treatment of immune checkpoint inhibitors to various stages of cancer. So initially, we saw the use of immune checkpoint inhibitors in patients with advanced cancers that had already relapsed from standard treatments such as chemotherapy. More recently, we've seen FDA approvals for patients with advanced cancers that have not received prior therapy, so therefore in the first-line setting, such as in lung cancer. And now, very impressively, we have also seen that immunotherapy with checkpoint inhibitors may help patients with early-stage cancers, either given after definitive therapy or given in a neoadjuvant forum, meaning before the definitive therapy. And currently, there are approvals for immunotherapy, for example, in earlier stage melanoma and in earlier stage lung cancer. Again, we see the broad activity of immune checkpoint inhibitors across tumor types. We also see a range of different response rates, therefore the degree to which the cancer may shrink from immune checkpoint inhibitors. And this ranges all the way from a 90% response rate in patients who have relapsed Hodgkin's lymphoma, down to patients with, say, relapsed lung cancer in the metastatic setting that may have a response rate of approximately 20%. But again, with the use of immunotherapy combinations and in the first-line setting, we are seeing some response rate that exceed those that have been depicted here. The other factor that has made immunotherapy extremely exciting for oncologists and all medicine providers, in fact, is this idea of improved and durable survival from immunotherapy. So as we mentioned before, immune checkpoint inhibitors try to unleash a specific T cell response against the tumor cell. So similarly to how we may have T cell responses against infections, when we are re-exposed to those infections, our immune systems have what is known as immunologic memory, an ability to mount an immune response against an infection that we may have previously encountered. Similarly, with the use of immune checkpoint inhibitors in cancers, we have this phenomenon of immunologic memory that may be sustained in a subset of patients, where we see what we call a tail on the curve phenomenon, where there is a subset of patients that appear to have improved and long-term survivals, related to the fact that there is a population of antigen-specific T cells that maintain our anti-tumor immunity against that particular cancer. And we have seen this phenomenon of durable survival in many tumor types, but notably in melanoma, renal cell carcinoma, and even in lung cancer from the use of immune checkpoint inhibitors. So this takes us to our first polling question. Please take a moment to answer the first inquiry polling question that's appearing on your screen now. You were asked these questions in the baseline survey as well, and let's see what you've learned so far. Moving on, what are the specific immune-related adverse events that we see from checkpoint inhibitors for cancer? So these toxicities are called immune-related adverse events, or sometimes they are called immune-mediated adverse events. And this is a term that globally refers to the toxicities associated with immune checkpoint inhibitors, either when they are given alone as monotherapy or in combination with other therapies, but are known to have an immunologic mechanism. So how are immune-related adverse events, or IRAEs, different from the traditional adverse events that we see with other typical cancer therapies, such as chemotherapy? So there are differences in terms of the incidence, the adverse event profile, the organ systems that are affected, as well as the time course of these events when comparing traditional chemotherapy to immunotherapy. First of all, in the early studies of these agents, we noted that the incidence of severe immune-related adverse events was quite small compared to what one would expect with chemotherapy. And really, this makes a massive difference for patients with cancer who already have often multiple other comorbidities that need to be managed concurrently with their cancer. Having an easier treatment overall ends up being more tolerable for the patient and may allow for an improvement in their quality of life alongside the management of their cancer. The second is the adverse event profile. As Andrew had mentioned, we're familiar with the typical side effects of chemotherapy that may occur and their timing. Usually a classic neutropenia that occurs 7 to 13 days after administration of chemotherapy, and then a rise in cell counts in the next 2 weeks prior to the next dosing of that chemotherapy. Other typical side effects such as alopecia, nausea, vomiting. These AEs are very different with immunotherapy. And as we'll mention in the coming slides, really any organ system in the body can be affected when a patient receives immunotherapy. In terms of affected organ systems, again, we are familiar with the organ systems that may be affected from systemic chemotherapy, but really any organ system in the body can be affected from immunotherapy, and we'll touch on these. The time course of chemotherapy adverse events, again, similarly reflects the timing of when chemotherapy is received. This, unfortunately, is not the case with immunotherapy. We appreciate that the majority of immune-related toxicities will occur in the first 3 months of administration, but really, immune toxicities can occur anytime after a patient has received immunotherapy and may even occur many years after they have received this treatment. So why and how do immune-related adverse events actually occur? So as was mentioned before, the mechanism of action of immunotherapy is to reignite our immune response against cancer and to allow our T cells and other related immunologic functions to eradicate a cancer cell in a similar way that we may eradicate infection, or in some instances, in a similar way to the mechanism of development of autoimmune conditions. So we see a great number of parallels between the development of immune-related adverse events and the development of de novo autoimmune conditions, conditions such as inflammatory arthritis, inflammatory bowel disease, skin rashes that may be autoimmune in nature. We see similar patterns. However, the mechanisms of these we found may be slightly different. In a certain subset of patients who have subclinical autoimmune disease, we have noticed that the use of immune checkpoint inhibitors may in fact unmask this autoimmune disease and cause immune-related adverse events. There are many potential mechanisms by which immune-related adverse events may develop. The first is due to this concept of shared antigens, that there may be protein products or antigens that are shared between tumor cells and the cells of a normal organ system. And when we unmask a T cell response, we see that the T cells may concurrently attack the tumor and the organ systems that share these same antigens, thus leading to an immune-related adverse event. There are other mechanisms that may be at play in the development of these toxicities, such as the development of antibodies and B-cell mediated toxicity, the expression of PD-1 or CTLA-4 on target tissue as well as tumor tissue, the implication of cytokines. Sometimes our germline genetics or HLAs may be implicated in those who develop immune-related toxicities versus not. And in more recent times, any talk on immunotherapy or immune-related adverse events would not be complete without mentioning the gut microbiome. So the microbes that reside in our gut or in other parts of the body may also be implicated in the development of immune-related toxicity. And what adds further complexity is that we also see this range of toxicities in patients treated with chemotherapy plus immunotherapy, or immunotherapy combined with other standard treatments. And then we are faced with the challenge of trying to tease out if this toxicity may be related to this traditional systemic therapy or to immunotherapy. We've also seen that the spectrum of toxicities in patients receiving combinations may be slightly different to those treated with immunotherapy alone, and that the incidence and severity of toxicity in those treated with combinations may in fact be higher. As we have noticed before, immune-related adverse events can affect any organ system in the body, and this may range from the more common toxicities to the more esoteric. So the more common organ systems that may be affected from immunotherapy include the endocrine glands, most commonly the thyroid gland. We can see both hyper and hypothyroidism that occurs from these agents, and in some cases, thyroiditis that presents as a transient hyperthyroidism followed by a prolonged hypothyroidism phase. Hypophysitis has also been described. This is mainly from the CTLA-4 inhibitors. Adrenal insufficiency, which must be weighed against the possibility of hypophysitis. And we also see both type 1 and type 2 diabetes. Type 2 diabetes often occurring as a side effect of corticosteroid therapy from the treatment of a different immune-related adverse event. Respiratory toxicity, so pneumonitis is the classic toxicity that occurs from PD-1 or PD-L1 monotherapy and is associated with the greatest number of fatalities from monotherapy and also in patients with lung cancer. But this is not the only respiratory toxicity that may occur from immunotherapy. We've also seen sarcoidosis and pleuritis occur from these agents. In patients treated with immunotherapy combinations, where immunotherapy is combined with chemotherapy, the two most common immune-related adverse events we've seen in patients with lung cancer has been hepatitis and nephritis, so involving the liver or the kidney. Immune-related arthritis is a very interesting phenomenon. This was not originally recognized as a toxicity of immunotherapy in the early studies and was often identified as separate entities, for example, an isolated arthralgia and isolated joint pain. But we at Hopkins were the first to describe that these may actually manifest as clear syndromes similar to the de novo autoimmune conditions. For example, a rheumatoid arthritis type phenomenon, a reactive arthritis type phenomenon, or a seronegative arthritis type phenomenon. So really, the arthritis side effects being an unusual but emerging toxicity from these agents. The more esoteric toxicities include neurologic immune-related adverse events, ocular immune-related adverse events, and cardiovascular immune-related adverse events. These are generally quite rare toxicities, but when they occur can be fairly dramatic. So neurologic adverse events can include encephalitis, aseptic meningitis, and myasthenia gravis. And the cardiovascular toxicities, which we will mention in our case-based discussion, include a variety of toxicities, but most concerningly, myocarditis. And then to end, the quintessential toxicity from the CTLN4 inhibitors was colitis. And we probably know or understand the most about this toxicity. Patients will usually present with abdominal pain, diarrhea, and hematochezia. And we have a well-worn path on how to treat these patients with either steroids or infliximab, TNF inhibition. The other most common toxicity that occurs is skin toxicities, which may present originally with no skin rash at all, but just with a non-specific pruritus, but a range of skin rashes can also occur with these agents. Another important feature of immune-related adverse events is their timing of occurrence. So the timing of these toxicities is highly variable, and it is important to tell any patient who has been treated with immunotherapy that once they receive immunotherapy, they may be at risk for the development of an immune-related adverse event really at any time point going forward. There are some classic timings, though, as to which immune-related adverse events may occur first. Rash is the most common immune-related adverse event to appear first and usually happens within the first month of treatment. This is followed by GI toxicities, either colitis, diarrhea, or liver toxicity. Then later, around the 3-month mark, we may see the emergence of endocrine toxicities. And again, we see here the tail on the curve with these classically is flattened because many of the endocrinopathies that occur from immunotherapy may not resolve. After that, we see the more esoteric toxicities, such as pneumonitis and others, which again may develop anywhere from early to much later in the time course of these patients' therapy. So how does this impact our encountering patients with immune-related adverse events in the ED? In a practical sense, it's important for ED physicians to be aware that immune-related adverse events can occur anytime following the initiation of an immune checkpoint inhibitor, including after only 1 dose. Therefore, the emergent presentations of immune-related adverse events should really be on the front lines of our thoughts anytime a patient has received immunotherapy and even after just 1 dose. The second important thing is that we do appreciate that there may be a delayed occurrence of immune-related adverse events, and these may occur many months even after the last dose of therapy. So ED providers should be aware to ask about whether a patient has received immunotherapy really any time in their treatment time course to know whether an immune-related adverse event needs to be on the differential. So therefore, in summary, in understanding immunotherapies and immune-related adverse events, we know that immune checkpoint inhibitors are a class of immunotherapies that work by unblocking a T-cell inhibitory signal. The cancer immunotherapy landscape has rapidly expanded in the last number of years, with many different patients suitable for treatment with immunotherapy, regardless of their tumor type, the tumor stage, or the time course as to when they should be receiving treatment, whether that be in the early stage or the later stage setting. Focusing on toxicity, we know that immunotherapy toxicity differs from other traditional cancer treatments, such as chemotherapy, in that the mechanisms of these toxicities are distinct. They appear to be autoimmune in nature. They can affect any organ system in the body, and they can occur at any time, including after just 1 dose of therapy to even after many months or years of therapy, or after a patient has even completed therapy. So from here, let's take a moment to answer the next inquiry polling question that's appearing on your screen right now. From here, we're going to move on to inquiry round 2, how to approach the assessment and management of patients with cancer presenting to the ED with potential immune-related adverse events, with a particular focus on the COVID-19 pandemic. So what do we need to know about the triage, diagnosis, and management of IRAEs in the ED? So first of all, as we mentioned before, the timing and accurate recognition and management of immune-related adverse events is paramount. We need to adopt a multidisciplinary approach that requires broad awareness and coordination among different specialists, including RED physicians. And therefore, it's important to anticipate that an immune-related toxicity can happen, to ask a patient whether they may have received immunotherapy with checkpoint inhibitors at some point in their treatment time course, to then choose the appropriate tests to detect a potential immune-related adverse events, to treat it appropriately, in some cases to monitor for them, to monitor for other toxicities, other immune-related toxicities that may occur, and then to think about prevention and whether this may be appropriate in this context. In terms of general recommendations for the treatment of immune-related adverse events, the treatment depends on the severity of the toxicity. So in those with grade 1 or mild toxicity, we would usually simply hold immunotherapy or institute supportive care, for example, topical therapy for those with a mild immune-related skin rash. In those with grade 2 toxicity, these would be patients who are moderately symptomatic, we would usually treat with low-dose corticosteroids at a dose of prednisone 0.5 to 1 milligram per kilogram per day, or the equivalent. In those with severe toxicities, those of a CTCAE severity grade 3 or greater, we would treat with higher doses of corticosteroids at a dose of 1 to 2 milligrams per kilogram of prednisone per day. In those patients with high-grade toxicities, the only exception to this would be those with endocrinopathies, in which we would not routinely treat with corticosteroids, but usually treat with hormone replacement alone. In those who receive corticosteroids, we would recommend tapering those steroids over 4 to 6 weeks, or until the severity is grade 1 or less, at which time we may safely discontinue corticosteroids with close monitoring. From here, let's move on to the diagnosis and management of organ-specific immune-related adverse events, with a specific focus on the big picture and key points for our emergency medicine professionals. So let's start with dermatologic immune-related adverse events, the more common or less serious of these. So some of the most common skin toxicities that may occur from immunotherapy is a nonspecific maculopapular rash, vitiligo, and other mild skin rashes. In these patients, we should always consider assessing the mucous membranes and the percentage of the body surface area involved in order to appropriately assign the grade of that toxicity. So in general, less than 10% body surface area is called mild or grade 1. 10 to 30% of body surface area involvement is called grade 2. And when greater than 30% of the body surface area is involved, we call it grade 3. The important things to consider in terms of management would be to rule out infectious causes such as cellulitis, to do a total body exam, including the mucosa, as we mentioned, to measure the distribution, the impact on activities of daily living, and as we mentioned before, to assess any prior autoimmune conditions or inflammatory dermatologic processes that may be important in assessing our differential. Some of the other toxicities that we sometimes see that are more serious would be those that have bullous features. So Bullish Dermatitis has been described from immune checkpoint inhibitors, as well as more serious toxicities such as Stevens-Johnson syndrome and toxic epidermal necrolysis. In these cases, usually immunotherapy is permanently discontinued. Again, the workup and treatment is very similar. We need to rule out infectious causes such as cellulitis, do a total body exam, measure the distribution, assess for involvement of the mucous membranes, which of course can be seen in Bullish Dermatitis, Stevens-Johnson syndrome, and toxic epidermal necrolysis, to assess the impact on ADLs, and assess for prior inflammatory dermatologic processes. Andrew, your thoughts from an emergency medicine perspective?
Yeah, thank you. Yeah, I love hearing you explain those, because as an emergency physician, I don't want to know just what I'm going to have to do in the emergency department, but I also want an idea of how you folks, how the oncologists think about this, because I know I'm going to find myself in a position of calling you, and I want to know the information that you're going to need. And often we find ourselves in the role of a teacher when we're calling the patient's primary care doctor, and maybe we're more familiar with this than they are. But I think what's really important for us to recognize in the emergency department is that these patients can come in with rashes soon after or months later from taking their checkpoint inhibitor. That we want to identify this, and we might not know the exact cause. Our differential might still include cellulitis, but we're gonna do what we always do when we see a rash. We're gonna assess the size of it, assess the significance of it. So if we see mucous membrane involvement, we're gonna worry about Stevens-Johnson syndrome. We're gonna treat accordingly. But finally, when we consult the oncologist, we're gonna come with all this information and make a disposition and make a treatment plan. So, the bigger the rash and the more severe it is, we're going to be giving higher doses of steroids. For a milder rash, we might be doing nothing. We might be doing topical corticosteroids. We're just making these decisions, in conjunction, in consultation with our oncology friends.
Yeah, I think the one factor or the one consideration we didn't discuss on those slides as well as this consideration for skin biopsy. So in patients in whom the rash may be severe, or particularly in those that have bullous formation, have a low threshold for calling your hopefully friendly neighboring dermatologist to do a skin biopsy as well, because sometimes we can see sort of rare subtypes of skin rashes that imply different management. So that would be the only extra thing I would mention.
Great.
So moving on from there, gastrointestinal IRAEs, I mentioned before, diarrhea and colitis, sort of the pathognomonic toxicity we see from CTLA-4 inhibitors, which is now part of the routine treatment for several cancers, such as melanoma, renal cell cancer, and some subsets of lung cancer. So in these patients, we typically notice they will present with abdominal pain, diarrhea, loose stools, hematochezia within the first 3 days or 10 weeks of therapy. Diarrhea, of course, is more common in patients getting these combinations. And the most important thing to think about is the complications of diarrhea and colitis, so perforation and sepsis, which is rare, but has been described in about 1% of patients who develop colitis. So again, our grading, in those who experience less than 4 loose stools in 24 hours, we would call this grade 1. Those who experience 4 to 6 loose stools in that time frame, grade 2, and they would qualify for corticosteroids. And in those with greater than 6 stools per day, or some unfortunate symptoms such as having loose stools overnight or incontinence, we would call these grade 3. And they would usually require inpatient admission and higher doses of corticosteroids. Some important considerations here is the frequency and volume of diarrhea to assess that in real time in the ED, to make sure to always do an abdominal CT to differentiate between diarrhea and colitis and to look for possible perforation, to do a comprehensive stool evaluation. Many of these patients may have received steroids for other reasons. They could easily have infections. Similarly, they could have received antibiotics for other reasons and could have C. diff. So do a panel to rule out infectious complications would be extremely important. And just for everybody's knowledge, in these patients, in those who don't improve after 24 to 48 hours of high-dose corticosteroids, TNF inhibition is very effective in these patients. And so sometimes if someone is coming in with a very severe colitis, we may even choose to do a TB spot or quantiferon test to get ourselves teed up for TNF inhibition if we feel we're going to probably pull that trigger in the next 24 to 48 hours. Andrew, your thoughts?
Yeah, thank you. So in the emergency department, we see many patients with abdominal pain, but when we have patients with a history of cancer, we're going to find out that they're on checkpoint inhibitors. And when we hear that, we're going to worry about diarrhea and colitis being caused with checkpoint inhibitors. We might not be able to make the specific diagnosis in the emergency department, but based on the severity of symptoms, we can start treatment. So as we saw before, the more severe the symptoms, the more likely we are to start corticosteroids. And we can make that decision in consultation with our oncology colleagues. This really isn't going to change the other things that we would typically do for this patient. So, if we find peritonitis on our physical exam, we're going to get that CT scan and look for perforation. It's rare and it can happen. So again, what we're seeing over and over, and I hope this message just, intentionally becomes a little repetitive for you, but we hope what you're seeing is that as we're evaluating patients for these immune-mediated adverse reactions, that you're bringing in the same differential that you had before, but now you're adding something. And so the thing that we saw that you're adding here is diarrhea and colitis caused by a checkpoint inhibitor.
So moving on from here, pneumonitis, the pulmonary immune-related adverse event. So in these patients, they often present with dyspnea, dry cough, wheeze, tachypnea, and hypoxia. Again, as we mentioned before, grade 2 pneumonitis implies radiographic change without symptoms. Usually we would withhold immunotherapy or tentatively continue with closed chest imaging monitoring. In those who are symptomatic, we usually will perform a comprehensive infectious workup to rule out other potential infections, for example, pneumonias that are extremely common, particularly in patients with lung cancer. We will do a CT of the chest, and we will treat usually empirically with corticosteroids. And in some cases, if we cannot effectively rule out infection to start off with, we may choose to treat empirically with antibiotics at the same time. Personally, if I'm able to get a bronchoscopy with BAL to truly rule out infection, I will try to do this before I start corticosteroids, particularly in patients who potentially can wait for a couple of hours in order to get this diagnosis nailed down. In patients who have high-grade symptoms, we would usually admit these patients, perform the same workup, definitely not delay in giving our empiric corticosteroids, and in some cases, empiric antimicrobials if this is on the differential. The most important things to rule out, of course, would be infection, disease progression, pulmonary embolus, and if a patient is fit enough, doing pulmonary function tests may be helpful in order to discern a problem with the actual interstitial process. Andrew, your thoughts?
Yeah, thank you. So these patients are coming to the emergency department, and there's a lot of overlap with other conditions that we're used to treating. So there's overlap with bronchitis, there's overlap with pneumonia. Patients with cancer make us worry about pulmonary embolism, right? So we're bringing that whole differential in, and now we're adding immune-mediated pneumonitis to our differential. And when we think of that, we're going to decide whether to treat with steroids. We're going to talk to the oncologist, and we're going to make a decision about whether this patient can wait for a tissue diagnosis, whether they can wait for that bronch, or whether we just need to start therapy right then and there. But again, if we don't think about it, if we don't think to make the call, if we don't identify that they're taking the checkpoint inhibitor, we won't be able to even ask the question of whether we can start treatment.
So moving on to the endocrine toxicities, as we mentioned before, thyroid dysfunction is very common, one of the most common side effects from all checkpoint inhibitors. The challenge here is that patients present with very non-specific symptoms, usually fatigue, anorexia, weight loss. These are all symptoms that could be related to their cancer, and therefore to identify thyroid dysfunction is usually tricky. And for this reason, we routinely monitor patients with a TSH while they're being treated with checkpoint inhibitors, since patients may be asymptomatic or it may be difficult to diagnose without this. Thankfully, it is relatively easy to treat. In those with hypothyroidism, we usually treat with hormonal supplementation with levothyroxine, starting with a dose of 1.6 micrograms per kilogram per day. And in those with thyrotoxicosis, we treat these patients supportively, usually with propranolol, and then we repeat our thyroid function tests in the next couple of weeks. As I mentioned before, in many patients, we see a combination of both, a transient hyperthyroidism followed by hypothyroidism. And this hypothyroidism may or may not resolve. Therefore, continuing to monitor the TSH and T4 through the course of therapy is important. The second set of endocrine toxicities to consider, again, present with these sort of non-specific symptoms of fatigue, sluggishness, weight loss, are adrenal insufficiency and hypophysitis. In these patients, the workup is somewhat similar. Usually what we would do is we would start with our thyroid function tests, and if we don't get a clear answer from that, we would do a panel of hormonal testing to test for either adrenal insufficiency or hypophysitis. The extra test to consider, of course, particularly when ruling out hypophysitis, is an MRI of brain with pituitary cuts to look for inflammation or enlargement of the pituitary gland. In this case, we would treat with corticosteroids and hormone replacement, depending on what hormones may have been knocked out by the hypophysitis. However, it is important to discern between this and adrenal insufficiency in terms of the timing of steroid replacement. As we know, those who have adrenal insufficiency or an adrenal crisis need very careful timing of their corticosteroids with hydrocortisone as well as fludrocortisone where appropriate, and in some cases may need additional fluid resuscitation for hypotension. Andrew, your thoughts?
So in the emergency department, again, it's important for us just to maintain a high degree of suspicion, right? So we see a lot of people with fatigue. And so now when we see patients with fatigue that have a history of cancer, taking checkpoint inhibitors or having taken them in the past, we need to, consider these, endocrine pathologies. And so when we think about these things, we all have different capabilities of what we can get done in the emergency department. And many of us can get a spot cortisol, and many of us can get TSH and T4. But we're going to talk to oncology and decide whether the patient needs to be admitted to get further endocrine testing. But again, we just want to keep these endocrine toxicities on our differential, so we can, if we can't do that testing right there, we can decide whether the patient needs to get admitted to get that testing done.
So in terms of other immune-related adverse events, we had said in our previous section that really any organ system in the body may be affected. So we've highlighted some of the common or severe organ systems, but really a host of organ systems may be affected. Hepatitis, the kidney with nephritis, cardiac, myocarditis, pericarditis, the neurologic adverse events, ocular, musculoskeletal, hematologic, and really for all of these, having a general list of some of the common presenting symptoms is important. Knowing the diagnostic evaluation for these, and of course the additional management. Thankfully, in most of these cases, corticosteroids is the first go-to. In some of these toxicities, they may be slightly different. For example, the neurologic toxicities for myasthenia gravis, Plex is often preferred. So in any of these toxicities, particularly when they're severe or esoteric, a low threshold for calling an organ specialist is usually appropriate. Andrew, your thoughts?
Yeah, I love that table as something to have for reference, so if you all want to, take a snapshot of that and keep it on your phone, because it's great to know, when we're going to be seeing these patients, that toxicity can literally manifest, anywhere in the body, in places that we're not necessarily going to talk about again today, or more specifically today, but that we can recognize that, and in most cases the treatment is steroids. Now, if you look at that table, you can find that there's nuance, right? And that's one of the great things about emergency medicine, is that we become experts in taking the first step in managing all these interesting disease processes, but we also recognize that there's this whole world of other treatments after that, that we don't have to have on the front of our mind, on the tip of our tongue, but we know it's out there. And so if that's a great table to have a snapshot of and recognize that we can get help from the oncologists and from and from the admitting team, in deciding on what to do when we see these patients.
The other area that is important to touch on is this area of steroid refractory immune-related adverse events. So in a subset of patients, they will not respond to corticosteroids, or their toxicity may not improve. And there are sometimes further immunosuppressive approaches that may be helpful, depending on the organ system involved. For example, those patients with diarrhea or colitis, if they don't respond after a couple of days of corticosteroids, we would usually try to treat with TNF inhibition, either with infliximab or with gut-specific immunomodulators such as vedolizumab that has been used for the treatment of inflammatory bowel disease. Similarly, in patients with hepatitis, we may be able to treat with mycophenolate mofetil. In patients with pneumonitis, there is no current standard, so options include infliximab, mycophenolate, or IVIG. In those with renal failure, similarly, infliximab or mycophenolate mofetil may be used, but other approaches may also be appropriate, such as azathioprine, cyclophosphamide, or cyclosporin. For the neurologic toxicities, IVIG may be useful. And as I had mentioned before, plasmapheresis for myasthenia gravis has been reported. The use of rituximab for certain encephalopathies have been reported. For cardiac toxicities, we may use ATG and other therapies. And for rheumatologic toxicities, it depends on the type of rheumatologic toxicity as to what immunosuppressive approach may be appropriate. Andrew, your thoughts from an ED perspective.
Thank you. So in the emergency department, and it's important for us to know that in general, we're going to be treating these with corticosteroids, and we're going to be starting steroids, in consultation with, the patient's oncologist. But it's great for us to understand that if that's not working, there's going to be other therapies. There are going to be downstream therapies that are going to be tried, if the patient's not responding well. And so that might not be something that we're starting directly in the emergency department, but that's something we should be familiar with, when we're talking, with our colleagues and we're making the decision to get these patients admitted.
So from here, I'd like to take a moment to answer the next inquiry polling question that's appearing on your screen now.
Thank you. So we have just gotten this great background from our oncologist, Dr. Jurishka Naidu, about the mechanism of these medications, these checkpoint inhibitors, how they work against cancer, and how they cause adverse events. And now we've heard all that, and we've heard all this detail about the adverse events. We're going to bring it back down and just go through a set of cases that are going to be things that you are going to be seeing in the emergency department. So we'll take all the information you've just heard and put it in the context of some patient interactions that I think you are going to be seeing in your emergency department. So our first case, we have a 60-year-old woman presenting with kidney cancer, or 60-year-old woman with a history of kidney cancer, and she's presenting with fatigue. So we see patients with fatigue every day. We see, patients with non-specific symptoms like her, and she's saying she has a headache refractory to over-the-counter analgesics. Otherwise, a negative review of systems. She's been taking an antidepressant for a year. She says, "Oh, I'm not taking any other medications. Are you taking other medications?" "No." We get a cancer treatment history, and she said, "Oh yeah, I have this wallet card, and the wallet card shows that she was actually treated with a combination of immune checkpoint inhibitors 4 months ago. So she was taking nivolumab and ipilimumab." So our physical examination, she's afebrile, her heart rate's 112, blood pressure 90/50, respiratory rate 22, setting 98% on room air. And she's depressed and anxious. She's not suicidal, no sign of a psychiatric emergency. She's got a vague headache, right? She's orthostatic, right? So we see these abnormal vital signs. We have a patient with a vague headache, and we don't really have enough to make a specific diagnosis, but we're definitely concerned because we attended this lecture and we know that we should have a high index of suspicion for adverse, immune-mediated adverse reactions in patients that have taken checkpoint inhibitors like she's taken. We get a CT scan, no abnormalities, we get labs, and superficially unremarkable, although we do notice there's some hyponatremia and hyperkalemia, and we recognize that as something that can point to adrenal insufficiency, especially in the context of somebody who's hypotensive. So we build a differential. Of course, we always worry about sepsis in somebody that's hypotensive and tachycardic. And I don't know about where you work, but where I work, my epic is going to be flagging sepsis alarms. Then we need to think about that and treat that. I worry about brain mets in somebody with a history of cancer and headache. But now, because I've attended this lecture, I've added to my differential diagnosis immune-mediated hypophysitis, and that's pituitary inflammation, and immune-mediated adrenal insufficiency. So what am I going to do? I'm going to discuss this with the oncology provider, right? The oncologist can really be my ally in figuring out how to treat these people, and my ally in figuring out a disposition for them. In this case, I'm hospitalizing this patient, right? Like we're seeing somebody who's hypotensive, we're seeing somebody who's tachycardic, and we might not be able to make the diagnosis right then and there, but we know they need to be in the hospital. In conjunction with hospitalization, we're going to give them antibiotics, right? We haven't excluded sepsis, but we're also now going to consider giving a corticosteroid like prednisone. We'll choose that dose probably in consultation with the oncologist. And Dr. Naidu showed us earlier that there's a range in steroids depending on the severity of the patient's presentation. After they get admitted, they're going to have cortisol and ACTH levels checked and pituitary hormone levels checked. But the important thing for us to know is that we're recognizing not just that they're sick, right? Any good emergency physician sees a hypotensive tachycardic patient knows that they're sick, but also recognizing that there's the potential for these immune-mediated adverse reactions, and that we're going to need to consider starting steroids, and we're going to want to talk to the oncologist. Now, please take a minute to answer the next polling question appearing on your screen. So our second case, this is a 62-year-old man with a history of lung cancer presenting with a rash. And again, we're going to hear this over and over again. These patients are coming in with complaints that we already see every day. So we already see people with rashes every day. And today the lesson is we're going to add something else to our differential diagnosis. So this patient started durvalumab 2 months ago. And if we didn't remember it from this presentation, we Google it and we're like, oh, durvalumab, yes, that's a checkpoint inhibitor. And in this case, the rash covers more than 30% of the body surface area. So it's a pretty significant distribution, this rash. And there's blister formation. It's a pretty significant rash. What's on our differential? Again, cellulitis, right? So common things being common, we can't exclude cellulitis from our differential. Drug hypersensitivity reaction. But now, because we've attended this lecture, because we've expanded our differential, we're also thinking immunotherapy-related rash. And as we saw earlier, these rashes can happen soon after starting checkpoint inhibitors and for months after they can start. In some cases, they can start after a patient stopped these drugs. So for mild severity, we might give topical steroids, low to moderate potency. In this case, this is more than 30% body surface area and there's blistering. This patient needs systemic steroids. We're going to admit the patient to the hospital and start these systemic steroids. And we can talk to the oncologist to help facilitate the disposition, help choose a steroid dose, and decide how soon or if they need a derm evaluation, how soon they need a tissue diagnosis. And we're also, if we haven't excluded cellulitis, we're giving this patient antibiotics, right? So again, we're just taking that old differential that we have, and we're not taking things off necessarily, but we're adding to it. And what we're adding here is checkpoint inhibitor immune-mediated adverse reaction. Of course, we want to be on the lookout for mucous membrane involvement, because if we see that, that would signal Stevens-Johnson, toxic epidermal necrolysis. That's rare, but it can occur. So of course, we're going to be on the lookout for that. And the treatment, again, would be steroids, but also the treatment that we would give for anybody with Stevens-Johnson, which would be to try to get them to a burn unit and try to get our dermatology colleagues involved. Now, take a moment to answer the next polling question appearing on your screen. Our next case, case 3. We have a 77-year-old man presenting with lung cancer. So this patient has trouble breathing, right? And again, this is a typical complaint that we're seeing, right? So these aren't patients coming in with exotic chief complaints. And if we don't expand our differential, if we're not thinking deeply about it, right? This could look just like one of our patients with, bronchitis or pneumonia that we're already seeing every day. This patient has sinus congestion. They were seen in urgent care a week ago, and they were given an antibiotic. They have a cough. They have chest tightness. They have shortness of breath. And they're taking warfarin, 5 milligrams daily, and that's always a red flag for us because we know that means there's at least some history of propensity to clot or thromboembolic disease. This patient is taking albuterol, so there's a history of bronchospasm, reactive airway disease, past history of DVT, which reinforces our concern that this patient has a history of thromboembolic disease, and we see it written right there on the chart. And we want to know what medications they're taking for cancer, and sure enough, they're taking atezolizumab, and atezolizumab, of course, is another checkpoint inhibitor. And if we don't know from remembering it, we will know from looking at the patient's wallet card. We can know from talking to the oncologist. We can know from Googling it, right? But we'll recognize that atezolizumab is a checkpoint inhibitor. Temperature is 99.9, heart rate 102, blood pressure 118/68, 92% on room air. So, we're worried because we're seeing mild hypoxia. Respiratory rate 24 per minute. So this patient's tachypnic. And on examination, we're hearing bibasilar RALs. We get a chest X-ray and it shows infiltrates at the bilateral bases and a right pleural effusion. We get laboratory data. It shows some anemia, but it's otherwise unremarkable. So this is a patient that we'll commonly see, somebody with a history of thromboembolic disease, with a history of bronchospasm, coming in with a respiratory complaint. They also have some congestion, right? So our differential is huge. The chest X-ray shows infiltrates. So that's suggesting, perhaps a pneumonia or something else. But so our differential diagnosis and next steps here. So first, our differential. We're thinking about pneumonia, right? So we have a patient with infiltrates on chest X-ray. We're also thinking about coronavirus. So it's 2020. We have a patient with infiltrates and tachypnea. So of course, coronavirus has to be high on our differential diagnosis. We're worried about worsening lung cancer, lymphangitic disease spread. I'm worried about pulmonary embolism, right? So could the infiltrates actually not be the real problem here, but could there be an underlying blood clot that's really, really causing our problem today? But finally, because we attended this lecture, because we're now thinking about it, immune-mediated pneumonitis. And at this point, I'd like to ask our oncologist, Jerishka, how do we sort out the difference here between pneumonia, and COVID-19 and immune-mediated pneumonitis? Like, how do we figure all that out right now in the age of COVID?
I think the answer is with difficulty. So this has been a huge area of concern, for those who are treating patients with cancer, with immunotherapy, and then of course the current pandemic. So I think really it's important to know what these differential diagnoses and to approach it in a systematic manner. Obviously, the most important thing currently is to rule out COVID-19, because that would take us down a completely different path and may take us down a path of isolating a patient, or in a practical sense, that patient going to a different part of the hospital. So I think, ruling that out first is very important. It's important to consider that pneumonitis is in fact a diagnosis of exclusion. It's a diagnosis when we have excluded the fact that this isn't COVID-19, this isn't bacterial pneumonia, a PE, or worsening cancer. And really, pneumonitis is left after all of those have been excluded. So we at Hopkins wrote a position paper on this that was published in the Journal for Immunotherapy and Cancer, where we talked a little bit about doing a rapid COVID-19 test to make sure we know what we're doing for patients in a practical sense immediately. Depending on the grade of the toxicity, then we would decide whether we were going to treat empirically with corticosteroids, with or without antibiotics, to do our standard infective workup, as we had mentioned. I think where things are a little bit different in the COVID-19 situation is the threshold for bronchoscopy, where previously, for example, I would have routinely asked for a bronchoscopy to help me to identify pneumonitis. Now, doing an aerosolizing procedure such as a bronchoscopy may not be in our best interests in the context of COVID-19. So we're only going to do that in selected cases, for example, patients who are not improving on standard therapy, and of course, bronchoscopy in those patients done at the end of the day so as to minimize transmission risk. So I think some very interesting tailoring that needs to be considered in the context of COVID-19.
Thank you. That's really helpful to hear. So I'll know to look out for that position paper, and I can look that up, and I talk to my oncologist and try to balance all these considerations when I'm thinking about COVID. But of course, I'm also thinking about pneumonia and immune-mediated pneumonitis. So yeah, in the emergency department, we're going to test for coronavirus. We're going to talk to the oncologist. Probably going to start antibiotics on the basis of seeing those infiltrates alone, in addition to what else we do. Of course, we're going to give oxygen to treat the hypoxia, and we're going to get a CT of the chest to further clarify what's going on in the chest. So in this case, the oxygenation improves with supplemental oxygen alone, and our chest CT shows ground glass opacities, which again, we were talking about COVID earlier. We hear that term a lot nowadays in conjunction with COVID. So hopefully, the COVID testing will help sort that out, and it'll help us make a decision what kind of isolation this patient needs, where they need to go in the hospital. But also, thankfully, our CT doesn't suggest a PE, so now that can move further down in our differential. These are just some other images of checkpoint inhibitor associated pneumonitis and the variability in the radiograph presentation. So management. So starting methylprednisolone IV, in this case, a higher dose, and we can make this decision in consultation with our oncology colleagues. Antibiotics, because we haven't, right? In the emergency department, we're not going to get that bronch back. We're not going to get that tissue diagnosis back. So we're still going to be treating for bacterial pneumonia until we know better. And we're going to meet the patient at the hospital, and the unit that they go to is going to depend on their coronavirus test result, and it's going to depend on our degree of suspicion for COVID. That's also going to help us decide, what level of isolation they need, and just admitting them for further respiratory virus testing, sputum culture, and pulmonary consult. Take a moment to answer the next polling question appearing on your screen. Case 4 is a woman aged 72 years old with lymphoma, and she's complaining of upset stomach. So again, a common chief complaint. She has nausea, she has crampy abdominal pain, increased flatus, diarrhea associated with incontinence this morning. She's taking an ACE inhibitor and a thiazide diuretic. She's taking oxycodone twice daily, taking Senna, history of constipation. And we get a history of what cancer drugs she's taken, and sure enough, she's been taking some checkpoint inhibitors, ipilimumab and nivolumab. She has a past history of hypertension and chronic pain. Physical examination, her temperature is 99, heart rate 96, blood pressure 110/64, so fairly unremarkable vitals. She's alert and oriented. Her lungs are clear. Her abdomen is hyperactive and diffuse tenderness, but we don't have any peritoneal signs. And her skin and mucous membrane exam suggests that she's lost some volume, that she's a little dehydrated. She's pale and she has poor turgor. So what are we going to do, right? We're bringing in the differential that we would have had before: viral gastroenteritis, C. diff, adverse reaction to another drug, malignant interstitial infiltrates. But now this immune-mediated colitis that Dr. Naidu told us about earlier, right? So we're taking our old differential, we're adding colitis, and we're going to decide, how we need to treat this patient. So we're going to, send for C. diff testing, send for stool culture testing, and that might not be available right away, but that's going to help make some decisions down the road for this patient. Get that abdominal CT scan, right? Somebody with diffuse tenderness and a history of treatment for cancer. And thankfully, we don't see a perforation. We don't see a surgical emergency, but we do see thickening of the colonic wall. We see pericolonic stranding. And as Dr. Naidu showed us earlier, colitis is a fairly common adverse effect associated with these drugs. Our labs show an elevated white count, hyponatremia and hyperkalemia, otherwise unremarkable. So what do we do? We discussed earlier that for somebody with disease that was this severe, our first line treatment would be steroids. So we're going to start steroids, and I'm going to talk to my oncology colleague and figure out what dose of steroids we should be starting in the emergency department. Something parenteral, but we'll figure out what dose. And of course, supportive care, right? This patient looked dehydrated, and we're going to bring him into the hospital so that hopefully as they do better, they can be transitioned to oral steroids. So other considerations. So again, we're not going to have a tissue diagnosis in the emergency department. So are we going to need a diagnostic test results before starting steroids? And the answer is, not necessarily. If the history points to immune-mediated colitis, we're going to start steroid immunosuppression in the emergency department. And, I'm going to do that. I'm going to talk to the oncologist to help me figure out what drug to give and what dose to choose. But we're going to get that started in the emergency department. Now, for somebody with mild diarrhea, we can consider budesonide, which is an oral non-absorbed steroid. Now, Dr. Naidu, how would I make this decision? Like, how would I know I'm treating a patient where I'm going to need to give a parenteral steroid and somebody that I can try to give an oral steroid?
Yeah, I think here the CTCA grading comes into place again. So asking a patient how many episodes of diarrhea they may have had in the last 24 hours, asking them if they have abdominal pain, or if you have had a CT, making sure there are no radiographic appearances consistent with colitis. So using these parameters to decide what grade of toxicity we're dealing with will help us to decide where on the scale we need to treat. If this is a high-grade case, more than 6 stools a day, abdominal pain, signs of colitis, we're going to go in straight with IV corticosteroids. You may even do a quantiferon or a TB spot test in case we need to think about TNF inhibition down the line. If this is a patient with less severe diarrhea, in the order of 4 stools or less, then calling the oncology fellow or attending to talk about budesonide may be appropriate. So assessing the grading is really key here. But of course, a low threshold for corticosteroids of any kind.
Thank you. Now take a moment to answer the next polling question appearing on your screen. Case 5. This is a 78-year-old man with a history of squamous cell skin cancer. Presents with a chief complaint of headache and altered mental status. So this patient, red flags abound: headache and fever, confusion, neck stiffness, right? We hear all that, and automatically our spidey sense is tingling, or we know this sounds concerning. Patients taking aspirin, diltiazem, benazepril. Past history of radiation for skin cancer, history of hypertension, history of AFib. Thankfully, the patient's family is with them and they have this wallet card, and we see that he's taking cemiplimab. We recognize this as a checkpoint inhibitor. So we're pretty concerned. We have somebody with confusion and lethargy, with a low-grade fever. Physical examination reflects that. The lungs are clear, and just kind of a vaguely weak and confused person. But obviously, we're really concerned whenever we hear that combination of a fever and confusion with headache. We're thinking about some pretty concerning things, and that differential includes sepsis, right? Somebody with fever and confusion, sepsis is always high in our differential diagnosis. Of course, meningoencephalitis, right? Somebody with headache, fever, and confusion. This is high in our differential too. But now, because we've attended this lecture, because we know to think about it, you're adding immune-mediated encephalitis to our differential diagnosis. So the next steps, again, we're taking an approach where we're treating the other things, but we're keeping the immune-mediated encephalitis on our differential. So we're giving antimicrobials, right? This is somebody that's going to need antibiotics and antivirals until we can exclude bacterial or viral meningitis. We're getting that lumbar puncture to make that diagnosis. This patient's getting a chest x-ray and a UA because we're still worried about sepsis from some other source. We're getting blood and urine cultures because we're still worried about sepsis from some other source. We're getting the oncologist involved because they can help us sort through this differential and help us figure out a disposition of this patient and help us decide what next therapies and testing are needed. In this case, an MRI will be helpful for diagnosing encephalitis. In some places, we can get this in the emergency department. In some places, this is going to be something that's going to happen after admission. But it's important to know that it's something that's going to need to happen down the road. So the lumbar puncture shows elevated lymphocyte count. Negative gram stain, glucose, and protein are slightly elevated. So this is tipping us away from perhaps a bacterial meningitis and pointing us more towards either a viral meningitis or checkpoint inhibitor encephalitis. And the MRI brain shows unilateral temporal enhancement, which could be consistent with encephalitis. So it's important for us to know today that immune-mediated encephalitis can really have a variable presentation. So patients can come in anywhere in the spectrum from mild symptoms, mild headache, all the way to severe symptoms, right? Confusion, fever, altered mental status. And that's important to keep it on your differential. Recognize this range of presentation and to get the MRI, or to at least get the patient on a road heading toward the MRI so they can make that radiographic diagnosis and to get that lumbar puncture so we can find these inflammatory findings in CSF and rule out diseases such as bacterial meningitis. So our treatment. So I get the oncologist on the phone. We talk about the case. We're still worried about immune-mediated encephalitis, and they suggest to me methylprednisolone 1 to 2 milligrams per kilogram daily. We keep the broad spectrum antibiotics and antivirals going, and we hospitalize this patient. And depending on where we are, depending on their nursing needs, they may need to go to the intensive care unit. Take a moment to answer the next polling question appearing on your screen. Case 6, a 61-year-old man with stage 4 non-small cell lung cancer. So this patient complains of chest pain and chest pressure. We see people with chest pain and chest pressure every day, but I know you all know where this is going, right? This is going to end up being related to a checkpoint inhibitor in this case, but we know it because we're going to have it on our differential. So this 61-year-old man was diagnosed last year with stage 4 non-small cell lung cancer, and he has a history of DVT and PE at diagnosis. He developed symptoms and presented to our department today with 3 days of shortness of breath with exertion, with muscle aches and weakness, and with fatigue. He's taking enoxaparin, taking HCTZ, and because we asked for the wallet card, because we look in the chart, we find out that he's taking nivolumab and ipilimumab. We recognize these as checkpoint inhibitors. Our physical examination, temp 99, patient's heart rate is 130 beats per minute. So we're really concerned about the tachycardia, 92/65 blood pressure. So we're finding hypotension on our exam. Patient's tachypnic, patient's mildly hypoxic, right? So a lot of red flags here. Diminished breath sounds on the right side, diminished heart sounds. Laboratory data. So we see elevated cardiac biomarkers, troponin 0.08, CK 800. We see elevated aminotransferases, ALT and AST are elevated. Lactate is elevated. Echo shows pericardial effusion with tamponade physiology and right pleural effusion. And ECG shows low voltage and pulsus alternans. So there's a lot going on here. Dr. Naidu, how do we unpack all this? Because I'm seeing signs of cardiac inflammation. I'm seeing signs of pericarditis. I'm seeing somebody who's hypotensive and tachycardic. How should I be thinking about this patient, and what next steps should I be thinking about?
I think you bring up, an excellent point. Given the fact that this is a patient who recently received immunotherapy and is coming in an acute presentation, this seems to be consistent with the diagnosis of myocarditis principally, given the troponin and the CK elevation. But you're right, pericarditis is still on our differential. In some ways, immune-related toxicity is a little simpler in the sense that the treatment is steroids, regardless of the location of the lesion, of whether this is pericarditis or myocarditis. So in a practical sense, I would call the cardiologist here to get them involved early with regard to obtaining a definitive diagnosis. And I know you'll talk about that. But I would have a low threshold for starting steroids given the sudden and severe presentation, and knowing that this is the toxicity associated with the highest rate of fatalities of the checkpoint inhibitor toxicity. So delay is what we don't want to have in this instance.
Thank you. And so I love that message of concern, knowing that this is one of the toxicities associated with the highest morbidity and mortality, but also that message of hope, which is that even if we can't completely unpack the myocarditis and the pericarditis and the cardiac biomarker elevation, that we know that the road in the emergency department is going to lead to steroids, and getting that started, and then getting our specialists involved to help make that definitive diagnosis. So as this case continues, a patient has a paracentesis and a pericardial drain placed, and we're able to get off 1.5 liters of bloody fluid. Cytology shows metastatic disease. Enoxaparin is held. Right. Follow-up echo is equivocal. CT shows a trace effusion. Ultimately, laboratory abnormalities resolve, and the patient is able to be discharged home. The echo shows resolved effusion. And so ultimately, this patient, is followed up, in outpatient clinic, and they present with significant recurrent chest pain for 18 hours, painful dyspnea, leg cramping and weakness. And the exam now shows strong bounding heart sounds, irregular heart rate, crackles in the lung bases. They're unable to lay flat for an EKG, and that inability to lay flat is another red flag for us. And it's going to make us consider our diagnosis here, and consider how we would evaluate and manage this person. So we're going to think about what is our differential now, and how would we evaluate and manage this patient in the emergency department. And Dr. Naidu, if you want to talk about here for a minute about these cardiac immune-related adverse events and how they present and how they're graded for us to think about in the emergency department.
Yeah, so I think there are a range of cardiac immune-related adverse events that have been appreciated. The toxicity that is associated with the greatest number of fatalities in those treated with immunotherapy combinations is myocarditis. And I would point you to a great paper in JAMA Oncology in the last 2 years that outlines this phenomenon, the largest ever reported series on these patients. But rarer toxicities can occur, such as pericarditis, arrhythmias, vasculitis, and even Takotsubo-like syndrome. The incidences of all these toxicities is remarkably low. Less than 1% of patients will generally develop these toxicities, but the concern, of course, is the fatality with the myocarditis. Similarly, the treatment is steroids first for nearly all of them. In the case of our particular case number 6, the other area I would love to point you to is, the new emergence of immune-related adverse event overlap syndromes. So there is a syndrome where patients may develop myocarditis, myositis, and myasthenia gravis as a trio of immune-related adverse events that almost exists concurrently. So in anyone who is being diagnosed with either one of these toxicities individually, it's important to think about the other toxicities and whether they may be co-occurring. And that has not been described with the other cardiac toxicities as yet that we know of.
No, and thank you so much for bringing that up, because now I'm having flashbacks because I've seen that patient. I've actually seen somebody with concurrent myocarditis and myasthenia gravis, and the management was challenging. But thankfully, because I've been involved in giving these presentations, I was able to talk to the oncologist, and I was able to get the neurologist on board, and we were all able to, get together and make a plan. And I think what was really interesting was the neurologist wasn't really familiar with that as an adverse event of the checkpoint inhibitors, right? So this is all new for a lot of people in the hospital, and I'm sure oncologists are finding themselves in this position all the time, but now maybe you'll find yourself in this position where you're teaching your colleague about these adverse events.
Absolutely.
So case 6 progresses, and our physical examination shows this EKG here, perhaps with decreased amplitude. The echo shows resolution of the pericardial effusion. CTA shows bilateral chronic PEs, pericardial effusion resolves, right lower lobe mass, significantly reduced in size, and reduction in mediastinal and hilar adenopathy. So over time, we can see below that the cardiac biomarkers improve from onset to day 7. We can see that the ALT improves from onset to day 7. We can see that the CK improves from onset to day 7. So this patient had immune checkpoint inhibitor related myocarditis with associated myositis, and it was treated successfully with a corticosteroid. Now there's a hierarchical definition of myocarditis accounting for different levels of evidence. And if you'd like to go through this for us, Dr. Naidu.
Sure. So I think the definition of myocarditis is sort of an evolving definition. And really this points to the fact that many patients present with this toxicity in an extreme condition to settings such as the ED. So being able to obtain a definitive diagnosis, sometimes with an endomyocardial biopsy, for example, may not be in the best interest of the patient, or may not be feasible in the context of the clinical presentation. So I think this is reflected in the definition. So in those, in an ideal world, we would get a biopsy of the cardiac muscle, And taking that together with troponins and ECG changes, as well as echo-related changes, we could definitively say that someone has myocarditis. But taking into account that sometimes we cannot obtain this biopsy, there are some suggested middle grounds as to when we can safely say a patient may have had myocarditis or not. So a diagnosis based on ECG findings and biomarkers, or imaging findings with biomarkers, or even a PET scan for probable myocarditis has been suggested. And then possible myocarditis is those who may only have one of these features. And really, this is helping us to sort of risk stratify who may have myocarditis or not, and who should be prioritized for a pathologic diagnosis depending on their clinical situation.
Yeah, thank you. And this is another slide that I'm going to want to take a screenshot of, for when I'm in the emergency department, because I'm not going to be able to memorize it. But from looking at this now, I know that when I'm worried about myocarditis, that I'm going to be doing some combination of ECG. I'm going to get biomarkers. I'm going to get an echo, and pull all this data together, and then talk to my oncology colleagues and figure out whether we're going to start empiric treatment for steroids. Then we probably will be, but whether we need to arrange for an expedited biopsy, or what the next step's going to be.
Mm-hmm.
So management here is to hospitalize this patient. Clearly, we're starting steroids, and we're arranging for that MRI and the biopsy if there's continued diagnostic uncertainty. And we're going to have this patient on cardiac monitoring, because we know that with myocarditis, there's a risk of dysrhythmia. Please take a moment to answer the next polling question appearing on your screen. So how has knowledge of immunotherapy and immune-related adverse event changed our practice in the emergency department? So hopefully, now that we've attended this presentation, we're going to ask about cancer diagnosis and treatment history, and any therapy that the patient has gotten in the past year or two, not just what they're taking right now, is relevant to us in the emergency department. We're going to talk to the oncologist. The oncologist can help us decide what the management should be for suspected immune-related adverse event. We're going to build a differential. Now our differential is going to include these immune-mediated adverse reactions if the patient has a history of immunotherapy for their cancer. So if they're taking one of these checkpoint inhibitors, we're going to bring our same old differential, but now we're going to add checkpoint inhibitor toxicity to our differential diagnosis. And finally, treatment. And this to me is the best message, it's the message of hope here, which is that we have the treatments available at our fingertips in the emergency department. These are corticosteroids, are by and large going to be our first line therapies. We're all familiar with using these. We use these every day. We're going to talk to our oncologist. We're going to choose a dose and a drug in consultation with them, but we're going to be choosing from a menu of drugs that we are all familiar with. Thank you for attending this presentation.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GKC860.